Bay for our CCU, ICU, because we're doing an early mobility study trial up there. And what's neat about this is, have you all used tilt tables before? Anybody use tilt tables? What have you used them for?
Spinal cord.
Okay, all right. And then what do you do once you get them up?
Exercise with them.
They don't fall over.
Exercise them
In standing.
in standing. All right. What we're looking at here, and I want you guys to think about, and we'll demonstrate a lot of different stuff of partial weight bearing exercise within the bed. This is the regular patient bed that they're in the CCU, ICU. So another piece of technology that helps us promote therapy earlier. All right, so what it does is basically a bed, goes up and down the same way as any other bed does. The legs of the bed can go up and down, more for a nursing function than what we would want to use it for therapy. But again, keep thinking like you were thinking upstairs. Okay, what else could we do with this? What else could we do to make our patients do more? Especially those two groups that were working on bed mobility and exercises for preambulation. If your patient cannot sit up over the side, some of those early venture patients, their O2 set drops as soon as you sit them up. For those of you who worked in acute care, or they can't tolerate, their heart rate goes through the roof, or their blood pressure drops as soon as you sit them up. So you can't do a whole lot in standing and sitting with them. What's another thing? Tell me what happens to patients' ankles. What do we need at our ankles for a normal sit to stand? Dorsiflexion, yes, to get nose over toes, right? To get that normal anterior translation of weight. What happens when a patient's in bed for a long time? Right, the covers are on their feet the whole time, so you lose that dorsiflexion, and that's really hard to get back. So one of the things with this that's really cool is being able to get around that problem. Because, you know what, somebody get in it while we're doing it. Who wants to get in it?
Kim wanted to.
Go ahead.
Okay.
All right, go ahead, hop on. We will strap you in.
Can I take off my shoes? Or no?
Okay, so scooch down. Yep, you're good there. You're good. We're good. So we're going to strap her in here before we raise her up.
It's so big for her. Yeah, I know.
All right. So even a patient who is pretty dependent, you're going to see what's happening here. Can anybody see what's happening to the foot plate? It's going to come up until it touches her feet. So what she's going to do is she's actually going to weight bear and stand on this foot plate. And you'll see as we keep a hold of this.
Look how quiet it is, too.
Okay. How does it feel as a patient? Good. Pretty good? Yeah. Now, if her O2 sat drops there, if that's where her tolerance is, well, you know what? Maybe let's take her down a little bit more. Let's see how she tolerates that. What can we do as therapists? Because if they're in the CCU, ICU, have any of you worked in CCU, ICU, been in clinicals? What do you do with a patient that's in bed that can't sit up? What kind of therapy are you doing? Passive range of motion, right. What do we know, what does that do for their strength and weight bearing? And not a whole lot. It preserves joint range of motion, and that's important. You know, preventing contractures is important. But one of the biggest things that happens in those prolonged immobility patients is their neuromuscular junctions break down. They actually get neuropathophysiology, and sometimes they never get that back. And it's the neural mechanism for the firing and recruitment of muscles. They never get that back fully. So the more we can do to get muscles firing early, the better. Anybody know how much muscle loss you have per week of immobility? It's about 10 to 15%, 1 to 3% per day. Muscle strength loss in healthy individuals. And we've all felt it when we've been sick with the flu for a day or two. You get up and your legs are wobbly. You know, we get that back pretty quick, but a patient who's been immobile for a long time, that's a big, big problem. So, looking at her in here, and if we can go further, we go further. What can you tell me about her feet? What about her ankles? Right, you're getting plantar aren't you? You're getting that dorsiflexion. Now, if this is as much as she can tolerate, I'm going to bring your feet up here a little bit. A bit more. Where is the sliders? I think I'm around here somewhere. Does somebody have the
They're behind
slider
me.
sheets? They're right behind you here. Okay. Because remember we talked about friction and how we can use all the different combinations of equipment. What I'm going to do here, who wants to help me? Do you want to help me on that side? Sure. Let's just bring the head of the bed down. And I'm going to tighten this up a little bit because I don't want to allow her too much movement here right now. Okay, let's go ahead and slide these down behind her. Let's get here. Oh, I've got a side and an end. There you go. Okay, we're going to slide these down behind you. So for today's purposes, you can help us a little bit. But with a patient, we might put them in the same way that we unfolded them before. Do you remember upstairs we folded and unfolded them? I'm going to pull them all the way down. Can you lift your bottom up, please? Yeah. And again, if the patient can do that, we make them do it. Yeah, make them do it as much as possible. Now, in this position, I'm starting this off. All right, just let your legs go. Let your legs go. Okay, push back up. Push, 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 push. Let them hold down. Push back up. All right, and you're getting what's happening at her ankles? Dorsiflexion. What are we getting? Even just laying there, do you feel like you're working at all? Which muscles do you think you're working?
There's a lot of weight on my feet.
A lot of weight on her feet, a lot on her heels. Which muscles is she working isometrically to keep herself in this position and stop herself from sliding? Gastrocs and quads, right, exactly. So that's going to help with what? Preventing muscle atrophy. Good, good. Preambulation strengthening, what are we doing? A lot more than passive range of motion, aren't we? And how hard did I work? You know, I mean, seriously, this is where the new technology is going, is really exciting for us because we can do so much more than we could before. What about if we got that hip patient? All right, there's an orange slide. There's a little orange thing there. Did I move that around? Go ahead and try and do some hip abduction right there. Doesn't matter which way. You know, you're kind of running into issues with the foot plate there. So, what's causing the difficulty with the foot plate? Friction. We have a solution for friction, don't we? Okay, now try it. It's a lot easier, isn't it? Alright. So we could have her. Now what else do we know? Think about your neural patients who are really weak on one side. Why do we use PNF? What's one of the key principles of PNF? Why do we use distal muscles in PNF? Overflow. Excellent. Overflow. What else do we know about laterality of overflow? When you've got a hemiparesis and you've got a CVA patient, do you ever work the good side? Yeah. Why? Correct. You get that overflow of activity. So, if you've got a hemi patient with real weak leg muscles, you can either work the unaffected leg in this position, or you can work the affected leg. Either way, you're getting muscle activity in the limb that you want. And what if she is flaccid? Does that matter here? I can give her as much support as I want here. I can support the knee if I want to, or I can make her work a little bit harder. We can what else? I was about to give you the answer. What else can I do to make her work harder? If her cardiopulmonary system can, oh, I probably need to unmark it again. If she can tolerate it cardiopulmonary wise, yes, let's raise her up a little bit more. Now in that position, is it harder to hold yourself there? All right, so we've just even isometrically made it more difficult for her. Go ahead and bend your knees again now. Okay, now I might also put a wedge between her knees so I'm not getting adduction of the hip in here, but can you lift this leg up for me a little bit? Even in that position, just to lift this leg up, what did it do for go ahead and raise this up. What did it do for this leg when I lifted this one up? Right, exactly. What about marching? Who can tell me, you guys touched on neuroplasticity? How many reps does it take for neuroplasticity to occur?
Thousands.
Hundreds and thousands. Hundreds and thousands. When you think about what we did upstairs, sitting your patient on the side of the bed, and if you want to work on marching and normal hip flexion initiation, how many reps do you get before you're exhausted? 10 10 reps maybe, you know. So think about some of the technology and using it to increase your number of reps. You could do 100 marches. Go ahead and just march in this, you know, just march. You know, now if that was too difficult, I might take the slider away, because it's hard with the sliders under, isn't it? Because you're constantly pushing against them. Oops. So in this position here, go ahead and march. A little bit easier.
Yeah. I'm not sliding.
Yeah. You're not sliding without the sliders in? Right. Who came up with the fish exercise? Okay, excellent exercise. Guess what? We could do it in here too. Can I give you this? Yeah. All right. We could do that here as well. Let's take this one out. You want to give your legs a rest? Push them up. So if we want to rest her legs, it's as easy as doing that. And then the straps are supporting it. Lift up again. Okay. And back. Okay, now just move your front. So we can now move through the fish exercises. You had done them in, I like the name of that. Yeah. So what are we working now? Obliques, trunk stuff. What about if you've got somebody who's in bed and they got, what grade were the abs on the patient upstairs? 1 to 2. So what does that mean? Right, nothing anti-gravity, not very much at all. But as we approach a more upright position, and somebody I think said this, that it's a little bit easier to hold the abs when you're already upright because you've got some passive stability from the spinal column, right? But up in this position, is it going to be easier for her to engage her abs here or supine? If I want you to come up here, reach for me, reach. Okay, come on back again. Reach. Good. Is that going to be easier here or in supine? Here. Here, correct. So if she gets up in here, now reach over here. Reach and touch me. Good. Okay, now what about integrating affected, unaffected side? What would we want to do? Cross midline. Right? Who was the patient with a good neglect? You had good neglect, yes. Right? So again, in this position, we can come in and we can do the scapular stuff. Okay, reach over that way. Reach. You know, and we're not hurting ourselves. We can do it in any range. We can start up here. In this position, it's going to make it harder to lower the bed down a little bit. Right? So in this particular exercise, we're going to make it harder by lowering the bed. For the legs and the quads and things, we're going to make it harder by increasing the elevation of the bed. But for the abs, we're going to make it harder and harder by lowering down to a more supine position. Go ahead and lay back again. And the further down we go, the harder she has to work to achieve those things. The other thing we can do is, what about if we want to stretch those gastrocs? Right? We can use this stuff, and again, new technology is emerging all the time, and I think it's kind of a really exciting time to be a therapist doing this stuff, because we can do so much more. We can do all this with a sedated, vented patient. You know, for right now, what do we do with sedated, vented patients? Range them, and that's it. You know, so really the opportunity that we have to prevent those neuromuscular problems that those patients develop, and that's why we're here, is to keep those patients moving. You know, mobility is everything for these people. And it makes our job a heck of a lot easier in rehab if we prevent the problems from happening in the first place. So if I just put her here, I can just leave her here, and look at the stretch I'm getting at her ankle. Great stretch for the gastroc. So using it for things like that. The sitting position, let's look at that. Any other questions on this? Let's raise it all the way up. I'm going to tighten this up. Okay, go ahead and push yourself up again. Here's another thing. What else? Consider your hemiplegic patients, right? Stroke patients. What is one of the big problems that we deal with stroke patients?
Blood pressure.
Blood pressure, but what about, you had it here, what were you doing when you were a stroke patient? Neglect. They forget about the one side. What do we know about symmetrical weight bearing? Why do we spend so much time trying to get them weight onto the affected side? Proprioception, relearn normal movement, relearn normal alignment. Do you touch on all the different approaches? Do you touch on Brunstrom and?
You guys have had that. Yeah.
Okay.